Okay, thank you for introduction. And also Dr. Losada, Dr. Ken, Dr. Nader, thank you for inviting us to be. I'm so happy to be here as a speaker, not just one of the residents. And okay, so I'm going to start with my presentation. But before the presentation, one thing I wanted to tell, because as you know, in Japan, the last 2 years has been a very difficult moment for us. But we got that this moment, and also I was sad. It was sad, but it was also very happy because I called a lot of friends from what I met in Loma Linda. So I'm very happy to be here to be able to thank you for all of you guys. And still, it's been there 2 years, but there's a lot of things we have to do. But anyways, we need continued support. It's the same as the dentistry, but anyways, thank you very much for everybody. Thank you. Closer. Okay. Okay. So from now, I'm going to talk about something that is we are already. Yesterday also we discussed about the anterior implant, but there's a lot of things going on in the anterior implant placement. But the reason I'm just going to talk with is something like Dr. Olivier was introducing one of his huge big guy who was the first patient for him, and also I'm going to introduce one of the patient. Before that, I'm going to say one of my assistant. She made it, and at the time was a very fun time. And when I was the second year, there was a lot of people, and the other is here. Olivier is not here yet. So I'm going to introduce one of my patients. Believe it or not, my first surgical patient was the patient something like this. So it cannot happen in Japan. We're just coming out from the dentistry, and the first patient I have to go through the implant treatment is something like that. So at the time, Dr. Khan and Dr. Losada, we went through all the things what we had to do at the time, and we did extraction and the placement of the implant immediately provisionalized. And at the time, there was no abutment for the zirconia or anything like that. So we are trying to get the optimize aesthetics. And then so we did it something like that. I'm going to mention about this case later on. But anyway, that is the time was 1999. At the same time, as we maybe the people who are here know about this kind of literature, and also that we're happy just because Dr. Losada announced yesterday. They're all now supposedly everybody here has all the data of the presentation, not the presentation, but the PDF file or something like that for our presentation, and also documentation of those kind of literatures. I'm going to just mention about a lot of the paper that came out from the Loma Linda, our department. So, anyways. So at the time, they were talking about a lot of the implant complications, about the surgical complications, implant loss, and bone loss, and things like that. So we have discussed so many times. Even already in 99, the result of average of the implant failure for the front teeth and the missing of the single tooth is very low. This is the paper, so maybe it's maybe it's the real life. Realistically, this number maybe it's going to be lower, but still the number is not bad. So it's already even before the year 2000, the average for the success rate it's pretty good. On the other hand, we are discussing aesthetic problems for implanting crowns is it's very difficult to do because there is 10% of the cases has problems of things like that from the data of this article. And also even after the 10 years, they had a summit and for the AO, and also they talking about what is, there was yesterday that we are doing some kind of the audience asking it is what the question, what do you think about and answering with the computers, with the iPhone or something like that. They did the same kind of things at the AO meeting, and it said, what is the challenge you think is for the implant treatment? And the result came out something like that. If you think about it, I'm not going to talk about the vertical ridge augmentation right now, but if you think about it, whenever I checked over here, the location is something that we have to really consider about what we are doing in its front teeth or anterior implant treatment. So if you calculate everything, it's going to be a big number. So still after 10 years, still older people are very much consider about and very it's challenging to do the aesthetic zone for the implant treatment. Also, the same year, 2010, also there is an auto review from the Cooper, and also there is talking about what's the center of the tissue, how much the discrepancy or something like the recession they have. At the average, I didn't calculate the average because so much range of it is from 500 of the pounds and up to the 1.5 millimeter. So it's almost like we never know. It's not predictable to see how the tissue is going to be after the treatment. So I'm going to just wanted to go through the factors of what is relating to for the front teeth aesthetics. And also here is I put as the implant geometry and things like that. It's, those kind of things is going to be changed, and most of the time is implant company present to do this is the best implant I ever come or something like that. So I'm not going to talk about those kind of things over here. Right now, whenever I wanted to talk about the development or the improvement of the computer or information IT, information or imaging, I think it has been better because before, when we started the program, still we didn't have any kind of the three-dimensional measurement of something we can do. So only thing is just taking photos and also the dental and also the panoramic X-ray. Those kind of things is the major things that we have to go through. But lately, the price-wise and many things that we can do it with with the cast and also later on Alvaro is going to talk about the three-dimensional and for the treatment for the CAT scans and things like that. Also, before I was using this medical CT, and also as you know, in Japan now and also before, and then once I went back to Japan, I realized that so many people are so much concerned about the exposure to the radiology. So even though they're taking them just for the dentist asking the patient to go to the CT for the medical, and some people they reject it. And also the exposure is, of course, it's big. And also we have the different system of the insurance system. We have the healthcare insurance, and also they provide a lot of the metal crowns and the inlays and things like that. So that's why it's if you go through the CT, it comes out like that. It's so much artifact, and you can't even see it sometimes. But lately, we have developed the dental CT, which can be seen a lot of the more details, and also lately we are just taking the CT all the time and retracting the lips, and instead of having it so those and the lips and laying on the buccal tissue, you can give you they can give you some idea what kind of the thickness. You can't really measure it, but you can get some information. So we have to put the patient and the exposure of the radiology. So we have to capture all the information that we can get from the one information. So I try to do that as many things as possible. So that's then this CT captures more information from the patient. So those kind of things that you can improve the radiology exposure, reduce the radiology exposure, and as I said, arch factor is very low, so I can see some more details, and also so that's why we can manipulate and we can know a lot of the more detailed information. And also, some CT cannot, you cannot count on the Hansfield unit. This is what we were really concerned, because before medical CT, you can just apply the Hansfield unit. Now everybody start using the dental CT, and no one is speaking about the Hansfield unit. But we can't forget about it. This is a very important part of the. Of course, it's for the teaching purpose, and also it's very the important thing. So some of the material they can count on the Hansfield unit, which is pretty important. Just I want to remind you, this is maybe you saw it last time, or maybe the dental school, or maybe a long time ago. But those kind of things can need to be that you have to remind it once you know the technology there, even the dental CT. You can say you can capture those kind of information. You know, before the patient, even though we do the implant, we know how hard the bone is going to be. Sorry about that. This is like a textbook, but what we did was what happened is as you know those kind of the measurement of the Hansfield unit, you know what kind of the data and what kind of the bone the high structure they have. But you know the real life is not something like that. What we're going to do, there's no exact boundaries in between those kind of the type of the bone. But what we have to do for the real life is like it depends on the what kind of the implant or what kind of the bone structure. What we're going to do is, as we know what the heart is, how hard the bone is, we manipulated how we drill the bone. Sometimes if the bone is soft, you drill, maybe downsize it, and after that you just put the implant. Those kind of things need to be done. And also the diagnostic tool has been developed. As you notice, we notice even like I showed it one of the dental CT. Now we can image what is the cross-sectional form of the front anterior area. But so even the anterior area, we can find it out what kind of the implant or that we're going to find it out. And yesterday also Dr. Khan was mentioning about what kind of the diameter of the wide implant or narrower implant will be better before it's wider when the narrower. Not only that, if you consider about the same household home housing, if you see it with those kind of the cross-sectional view, if you have the wide implant and if you have the narrower implant, you have a more the range to play with the narrower implant. Not only that, if you consider about the angulation, those are kind of things is very important for the front teeth. If you have the wide range and if you have the narrower, you have the more range to play with. So important thing is don't try to put your situation to be in a hard situation. If you have the narrower implant, maybe you're going to have the space or more the selection that you can choose where you place the implant. So what happened is that over here, so the reality was that the diagram was like a bone was there like all the time. But what happened, what we are talking about is yesterday also at the end of the seminar, everybody was talking about if the structure is there, most of the people wanted to go for the immediate placement or immediate loading or immediate improvisation. So before doing extraction, actually we have to know what the direction is of the existing root of the teeth, the front teeth. So those kind of data also, I think, in the USB memory, right?
Yeah.
Okay. So I'm not going to go the detail about that, but this, also those kind of the thing is also well described in the what the normal the range of the where they have the bone, which is we need for the immediate placement and also to obtain the primary stability. We need a structure to know before even the surgery. Then we find it out that they find it out that more than 80% of them is shaped something like that. Other materials that we have to know before the surgery is something that this is very conventional. So this is what you can do it very easily, and you can do this bone sounding as well. And as you know, maybe this you hear so many times, maybe 1,000 times, that you know the bone shape. The tissue, the biotype. And also there's the direct measurement was done before, and also that they said that just a visual assessment of the gingival biotype doesn't, you can't really trust it, but it's if you do it with the probing, you can just capture the image. And also what I did is, like I explained before with the dental CD, if you reflect the lip, upper lip, and you can see, you can capture the image of how thick the buccal tissue is. Those kind of the information is what you have to have before the surgery. So now what we know, that we know what the hard tissue or what is the situation that's on the tissue they have. So what we have to do, think about our software. Also this one that was done, so also all the information should be in the USB memory, so which is good about it. And also the Dr. Kans, this will find it out, so all the papilla and also the tissue is very much dependent on the bone height of the adjacent teeth, natural teeth. So they have they find out those kind of things, and also that Dr. Kaplani said he found out that he just suggested what is the treatment for each shape of the bone defect, and all you have to do is, like I explained, you have to know exactly what is the shape around the tissue is, and also that then they suggested what the treatment plan is. So if you think about it, even before the surgery, you have, if you see the patient, maybe it's better to have, you can capture something like a view, like something like that. So you have to measure which part, maybe there's a gingival object, and also underneath the gingiva, there is a lot of the structure underneath the bone and those kind of things. Then if you know what is the size and which location you need to place the implant, and the future architect, how it's going to be after the surgery. So those kind of the images remind me. So that's why I was thinking about maybe this, if they have the place we need to place the implant, and the adjacent teeth has a good bone around, maybe this they are just holding their soft tissue. So that's why I was thinking about maybe this is like a hanging bridge. So this I would thinking every time this is like a hanging bridge. So that's why if there's, I'm just very focused on the bony structure around the implant, future implant site. And also the reality for the diagram is not going to be something like that. Do the extraction after the bony structure is something like that, because so now we know that 80%, maybe 80% or plus or minus of the structure is something like this. So what we have to do is like we're placing an implant over here, just as Dr. Khan was just suggesting it yesterday. But lately, sometimes I use a straight implant. One of the reasons is because of this portion, if you drill it and you drill the finishing up the narrower diameter of the drill compared to the final drill, and if you're placing the implant, most of the time buccal bone, this side the paltal side of the implant kicks in the implant in front. That then eventually, because it's tapered, that's why if you drill it, you need to be careful. If you go for if you drill it, the implant angulation goes to the front. So, but if you use a straight implant, many times it doesn't happen. So that's why sometimes if it's very difficult to maintain this angulation all the time, sometimes it's one of the good ideas to use a straight implant as well. That is another reason that they are told it's very technique sensitive, because if you, I pointed out the 3 locations, if they miss the proper extraction, you just remove all the buccal bone, you have to, stage it. You can't do that. You can't proceed the immediate placement. So you have to stage it with bone graft, and then you have to try back it again. And even the osteotomy, if you miss it, if you did too much the big of the mess up the osteotomy, you have to graft it back again. So that's why it's very technique sensitive. So you gotta be really careful. Then knowing those kind of things, we have to know that do that treatment planning. Now we know what is structure and what we have to do. And is it going to be that, then we can find it out what is the treatment plan option is. But is it the only thing we have to do? No. Actually, the important thing is we have to listen to the patient. Because it's, our clinicians, yesterday, today, we are talking about those kind of things, peri-implantitis, what are the complications, da-da-da-da-da-da. But what would be a reality, maybe the patient is a pain is most concern or something like that. So it's so much discrepancy, that we are just watching this kind of the teeth and looking at the teeth and the size of the Olivier's first patient, right? But it's very much the differences. So that's why I was just looking at the literature. I don't think this one could support my thought, but anyways, there is one of this literature. What they did is even though taking a picture and asking the patient, you like it before or after the surgery, and they just for clinicians and patients they compare. And what they find out is they have the totally different way to think about it. So what the telling is avoid the improving their own subject. So what they say is we are just we have to listen to the patient. That Olivier was telling me that you have to listen to the patient what they wanted to have. They're very important. So that's why we have to listen to the patient, and if they what they want, do they want it to have because if the patient has never had an implant surgery, they never know what the implant is. So only thing is that they have to image or they get the information from the internet or something like that. So maybe they are thinking about they want to have the teeth, but what teeth they are thinking of is the teeth they had. So do they know the implant? Maybe they think the implant is the same as a natural teeth. Maybe we explain something like that way, but is it reality? No, actually it is not. So that's the things that we have to really consider about and talk to the patient and educate the patient. Maybe they say I don't like the pain. So maybe they're not going to do the surgery. You never know. But we have to talk about consider about all the things that we discuss, and I was telling and all the information. Maybe the patient wanted to have the blood graft and doing the implant. Maybe happy, or just having the FBD, it's partial denture over here like that. Or some of the patients, as long as the tissue is clean, maybe he doesn't want to do any kind of the job after that. You never know. So the final thing is experience, it's evidence. Because Olivier also talked about that evidence and the things but that's it. Even though on the paper they say something, does it apply to me all the time, or even though the same thing and it's good it works for Olivier, me, Alvaro, everybody? You never know. So what we have to do is, this one is just, I don't think it's all the more details is not necessary, because what this is, they are just doing a suggestion for a single tooth replacement. So what they did is don't do this, do this, do this, don't do this, something like that. So what they are doing is this, they have to find it out what they wanted to do under such circumstances for each patient. So what I did is after I went back home, I just find it out, okay, try to do that for myself, my level, maybe just I try to do that, something like that. And I made a diagram, if the anterior cases, if it is already edentulous, or you're missing, or they are trying to do that extraction, something like that. Then I just followed what I decided to do. So this is the case I explained very much the first time. It's been 14 years, but do I see this patient? Sadly, I've never known. I don't know. Maybe it's like yesterday Dr. Khan's patient. Maybe Facebook. Maybe she's gonna find me or what. I don't know. But the sad thing is, I don't know really. So what I have to do is just do the follow-up. So like I just did the. Usually we did it just a different way, but I just start putting the longest one from the experience in Japan. So I did. I decided one of the structure. Decided what I have to do. All the diagrams I decided, and kept doing the follow up to what I decided. Also, all those are the different cases, and some of them are just needed 2 stage, 1 stage, or immediately placed, or something like that. But what I did is just very close to the patient. I have to follow the patient, how they're doing. Also, I have to make sure what I decided to do was right or not. So, many cases, I don't think I have so many front cases like Dr. Khan does, but so far I don't have so much the bad cases. So maybe this one of the reasons is like Olivier said, like selection, patient selection is very important as well. So I just wanted to do the treatment only this I think I can go for it. So currently that's what I did. Because I said the reason I put it currently is because of the eight years ago I didn't do anything for the tissue graft or anything. I did a bone graft, but some of them was that. But lately, this is how I do lately. So finally, this is my case. So, okay, this is like a young patient that he is actually the fighter for the K1 fighter. You know, so I don't know if it's going to be the good case for doing an implant or not, but I was thinking about it. But anyways, he really wanted to have something that he doesn't want to have any kind of removable. So in the future, maybe this one is going to be out. But anyways, I got a referral from one of my friends. So that he wanted to have the implant replacement, replaced by the implant over here. So we did all the things I already discussed, and we did the WhatsApp, and then did the computer-based. So they have the bony structure, and then I did maybe that's I can get the primary stability, and I use those kind of image to educate the patient if he really wanted to have this kind of the procedure for that. The time of the surgery, I did an extraction. I use a surgical template. I'm using this case. I use a GC implant. Maybe you guys are not familiar with that. And I did the tissue graft on the buccal side, and also for the socket, I did the xenograft bone graft. And usually what I did in my private practice is I've had a lot of the, I'm thinking about should I do all the provisionalization, spending a lot of time for the day of the surgery, and or just doing the healing abutment, and later on I'm going to have time to play with the tissue. So right now I'm thinking about my way is like I'm just I prefer spending the time with those kind of things, because then I can sleep well, because I'm not I don't need to ask the patient, please don't bite or something like that, because we are giving the teeth, and also he is also the fighter. That's right. So that's why I didn't want to have those cases with the provisionalization. So I did the healing abutment. So after 4 months, what I did what I usually do is for those kind of procedure, I just give the sleep. And instead of pushing everything away, just try to manipulate and pushing this buccal tissue to push to the outside. And spending the time with provisional restoration. Then in this case, since I use zirconia, and I talked to the patient, and this is aesthetically, I don't like it. And so this one, eventually they need to be replaced. And also he wants to do that in crowns, but for him, it's okay at having it just a piece without any kind of removable. And also, what I told him was from the research, even the Dr. Kan's report was up to the 1.5 millimeter of the recession. So I wanted to stay away from those kind of recessions. So I want to see, okay, we're going to wait 1 year or two. And also, if there's something that you wanted to have the longer teeth, maybe we can trim it to try to do that. So overall, what happened is from before and now, what happened is like now is more to three-dimensional. And I'm going to just mention about the super integration. But anyway, so everything is budget. But before it's butt joint, and now the platform switching at the narrow. Before it's a wider diameter. But now it's narrower or regular at the diameter of the implant. And also instead of the addition, like Olivia said, maybe we're trying to do the preserve the structure or just try to support it. And before, I wanted to do the screw retained. Now, I want to have the more screw retained for sure, make sure. So that's the important thing so for to maintain for the long follow-up for the patient for long term. So now, I think it's before it's prosthetic driven, but now I think it's more the longer term prognosis driven. How I'm going to just see this patient for the rest of my life or something like that. So this is the photo functionalization of the titanium, and you can see those kind of image from the YouTube, and if you just put it light, and they can improve the quality of the osseointegration. So anyways, we needed a longer support for even the tissue and even the patient themselves. Sorry, I'm going to wrap it up in 3 minutes. So. Almost my conclusion is almost like same as Dr. Olivia says, that that's understanding what the patient wants and never promise the result. That is the thing is that we have to, we can't really promise what we can provide. Of course, we try the best, but sometimes it's the medical field, we can't really promise it. And also the material and your technique, and our technique, and the patient smoker or not, and those kind of factors, we have to know the limitation. So that's why we have to go beyond something that we cannot do. And also, this, like I said, try to do establish the way you just do the diagnostic, and also the method that you have to do, what we're going to do for that. And if you're going to do that at the immediate loading or you are not doing it, those kind of things, you have to decide by yourself. Because once I'm getting out from here, no faculty is there, so you have to decide yourself. It's the same thing after the school, you have to decide it. And also, what we can do, we don't want to have the mistake by myself. So what I have to do is from the people who've done it, been there, those kind of people, listen to them. Like Dr. Khan was there, and the Dr. Sara, the climber is here. If something bad happens, just listen to them and try to not to have gonna happen to my patient. And just for myself, we have to follow up the patient because Dr. Shana yesterday talked about that 60% of his patient is coming from the outside. Somebody is a mess. So we don't want to have those kind of things. We don't want to produce those kind of implantations. So what you have to do is do what you have to do. So that is what we have to do today. And also, I'm going to just wrap it up. And so this is Tokyo. So now my classmate is from Spain, and we are just trying to do this. Which one? Or Turkey? Anyways, we're gonna have the Olympic Game, but hopefully the 2020 going to be in Tokyo. I'm going to now have the practice in Tokyo. The Tokyo area Olympic game is going to be around here, and my office is going to be here. So please stop by if you come to the Tokyo. Now it's a very good season in Tokyo. The cherry blossom is there.
It's cool.
I have my wife and 3 kids. Okay, sorry about the long presentation, but thank you for the listening. Thank you very much.
I must say that I think Dr. Lozada, Dr. Kleiman, we all agree Taka is one of the probably nicest residents. I mean, really, really nice person, really helpful. I mean, anytime we need him, well, he's a resident. He's there for us. So you know, that's why during his presentation, I'm here for him too. You know, so no. But the thing is this. Okay, so you're trying to basically, you know, cram the whole Bible on treatment planning, diagnosis, on implant aesthetics in 30 minutes here. Just curious. At the very beginning of the presentation, you mentioned about CBCT scanning. All right. I mean, first of all, in your opinion, how important it is in your diagnostic process? I mean, is it like a must, or can we just do a PA? Would that be enough, or?
I think it's lately more important for not only us. Actually, it's very good material to educate the patient in what situation they have in it. Because for them, it's to capture the image from the 2-dimensional, just PA or panoramic X-ray, sometimes it's very difficult. So
Okay.
I think
So I'm just curious. Let's say you have a patient missing number 8, central incisor, heel site, all right, that means missing, right? So now you say, well, we're going to do a CBCT scan to look at the bone profile. Question is, nowadays, everybody keeps focusing that implant therapy should be prosthetic driven. In other words, the implant should be placed within the confines of your prosthesis. Am I making sense? Right? So under such circumstances, I mean, when you do the CBCT scan, are you going to have a radiographic template, or you can just go ahead, let's do a scan without the tube? I'm just curious. Does it matter?
right now, I think it's for the missing one.
Missing one tooth.
One tooth.
That's right.
Okay, for the missing one tooth, maybe I'm going to go for the without it.
Without it.
Yes.
Okay. So, but without it, how would you know, if you don't know the sagittal view of the tooth, the profile of the tooth, so what is the value of that scan? So let's say you're missing some bone, but are you missing the bone where the tooth need to be? Or if you have some bone, is the bone enough to put an implant there so that the tooth will end up to be at the right place? Do you understand my question? Mm-hmm. So what is the value of that CT scan?
The way I will do is maybe I will go for the CBCT scan first and then discuss with the patient, and also at the same time, then after that, maybe say if I find it out, maybe I need more details about how much the bone we need or something like that. Then I will go for the template.
However, you just told the audience earlier that, you know, I mean, around 36 minutes ago that, you know, your patients worry about the radiation. Mm-hmm. So you're sapping once, sapping twice?
No, actually, not twice.
But you say that first you're going to do it without the, you know, radiation.
So you mean it's, I'm going to work on the CAT scan maybe, and then after that I will just do the surgical template, but I'm not going to go for the surgical template with the radiograph. I will go take a second step.
So I'm just curious, how significant or insignificant that? I just want to ask Dr. Lozada here, since, you know, he's probably very experienced in this. So you see the question. So patients missing a tooth. All right, we know we want it to be prosthetic driven. So ideally is probably have a radiographic template in there, right? So would you go ahead and take a radiograph and be without the template? Because obviously it takes time to make that template, right? So when would you do it, or would you just do it once with the radiographic template? Where do you stand on that?
I think I will do it with the radiographic template. That's where you gain most of the information. Without it, it's just information, but incomplete. there's so much that we can learn from the presence of the ideal location of the tooth that I think is worth it to prepare and then take the radiograph.
Okay, so just to further on the question a little bit. So now we all know as practitioners, in my opinion, the first appointment, that consultation appointment is critical in getting the patients accepting or not accepting the treatment, right? And usually, because as a patient, when I walk into the surgeon's office, if I'm missing a tooth, hopefully not, that I'm going to ask him, I want to know with that first appointment, I want to get some idea, can I do it or not? Is it possible or not? And so now you're telling me you're not going to take the radiograph and we need to wait for another appointment. So how do you feel about that? I mean, what's your experience on dealing with situations like that?
I think you are the one that dictates the pace that you want to run your practice. If you want those patients to accept, probably you have to be very direct and somehow convince them to accept the treatment, maybe by doing gestures or showing them stuff. But the reality is, if you want to develop the pace of your practice with digital information, as Taka showed here very nicely, and you tell them the possibilities of placing the implants this way, that way, I think those patients can be a good referral for other patients. I mean, it's not that they're not going to refer you if you just talk to them without the digital support, but I think it's a matter of how you want to create your image.
Sure. So again, for the audience, I think that's a very important thing about, because I think digital imaging is very important, but with the presence of prosthetic-driven, I think that's very key there. Then you also mentioned to the audience that, well, you talk about the implant placement for immediate provisionalization, and you talk about a lot of times you do not provisionalize in your practice then, right? That's the trend there. Do you feel, frankly, from your experience that is there any benefit of putting a provisional in there at all? I mean, is there even any benefit right after implant placement?
To be honest, having this, the clinic by myself, like time consuming, maybe it's good if we can do it. But also, most of the patients, what I don't do the provisionalization, they have the natural teeth right next to each other.
Sure.
So actually, the bonding to the right next to each other it works fine.
So typically, that's another question I was going to ask you. So if you don't place a provisional of an implant, I mean, you lieu with all the grafting. So typically for the provisional, you just bond like a tooth to the adjacent teeth. Is that typically what you do in your practice?
Try to do. Yeah, basically that because I put the healing abutment anyways. So most of that, like I showed you, it's rounded, just the round point. Sure. So actually, we cannot play with anything. So, but the reasons I decided to do that case is I know that if you have this a good enough amount of the tissue, we can not play with, but we can manipulate it even after the implant placement. I mean, if the implant is also integrated. Okay. So that's why I didn't want to spend so much time and wanted to put the patient not to bite or anything.
Sure. I'm just curious. Can I see a hand from the audience here? How many of you? Hi, Cliff. Nice to see you. Okay. I saw a friend, so I didn't say hi. Sorry. How many of you, when you do when you do, let's say, anterior tooth, all right, you do a CT scanning? How many? Okay. How many do not? Nobody dare to raise their hand. All right, it's okay. Now, how many of you, when you do immediate implant placement in the socket, obviously socket, you will put a provisional in there? How many do that? How many? Okay, that's great. How many of you will do like what Taka does, that just leave it, just put a healing abutment in there? Sometimes, depending on whether the implant is stable or not. So that leads a very interesting question. So, you talk about implant stability is very important, right? So what happens if you do an immediate implant placement? The implant, is a little bit spinning. What do you do? How do you handle it in your practice? How many will leave it in if the implant is spinning? How many will remove it? Okay? So, you know, Dr. Kleiman, what would you do if the implant is spinning when you do immediate implant placement on this tube?
Well, if you have enough bone to place a wider implant, I remove the implant spinning and change for one wider. In case that you don't have enough bone, well, I leave the implant and wait what happened. But in the primary stability, you know that is an important issue for the osseointegration. So really, I try to get primary stability.
You try to. So if the implants loose, you probably will remove it, right? We'll try to remove it.
If I have enough bone.
All right, all right. Now this implant stability thing is a very mythical thing. Along the way, as we have more speakers present, we'll probably discuss a little bit more about it. So again, Taka, I mean, it's wonderful to have you back. We want to see you more often, and it is a really, really wonderful presentation. Thank you very much. We're going to have a break right now, and what time will the break finish? 10:40.